by Dr. GP speaking on post-refractive ectasia. Ma'am, is there? Good.
Yeah.
Yes, ma'am. Over to you.
Yeah. Thank you so much. My thanks to AIOS, the CLAO, and the ECLA for having me here. Even as laser vision correction was being celebrated as the most common and the most successful surgery performed in the world, the 2005 Ridley the medal lecture bore an ominous title. Dr. Patrick Condon concluded his lecture on an optimistic note. But the reason for his optimism was not so much what was stated as what was implied in terms of the terms and conditions that applied to that optimism. And these conditions hold true even today. The number of publications on the subject has increased in the last 2 decades, indicating an growing interest in the subject and an awareness of its importance. The true incidence in the strictest statistical purity of the term is not known, but that's because this condition is largely underdiagnosed, underreported, and relatively ill understood. But post-refractive ectasia is reported to be at least 4 times more frequently after LASIK as compared to the other refractive surgeries. But let's not forget that LASIK is also performed in much higher numbers than the other procedures. By all accounts, the biggest risk factor for post-refractive ectasia is an abnormal topography. Subclinical or form thrust keratoconus or an suspicious topography accounts for about 50 to 75% of ectasia cases. While these represent the intrinsic vulnerability of the cornea, there can be extrinsic forces like eye rubbing or treatment-related factors which can render a normal cornea weak. So pre-operative screening really is looking for eyes at risk for ectasia using diagnostic tools that have evolved over the last several years, from topography to tomography, including aberrometry and now corneal biomechanics. But the preparation for a patient really begins with ectasia assessment. While the original guidelines that were given were that if pre-operative corneal thickness of 500 microns and an estimated post-operative residual stromal bed of 250 to 300 microns should keep the cornea safe, we'll all agree that these form very broad guidelines. And we know that pachymetry itself has a large distribution even within a normal population. So the first time, Randleman introduced a more individualized or quantifiable risk score system where 5 important parameters were taken into consideration, and he could assign a quantitative score for the risk that the cornea was being subjected to. Which here again, we now know the limitations of a placebo-based topography system. Rather than looking at how much cornea is left behind, the PTA looks at how much cornea has been removed or altered, either by ablation or by excision or by even a flap creation. Now, these have been validated by several studies. Then we also had several reports of eyes which were considered no risk or low risk and still developed ectasia, and the converse as well. And 2 possible explanations for this is that these consider measuring either pachymetry or the ablation depth or the lenticule depth, which are all unidimensional. But the ablation that is created within the cornea is 3-dimensional. If you think of a spherocylindrical correction, or if you think about how it varies with the ablation diameter, you need to consider the volume of the cornea that is removed. And the vital change that is being introduced is in the purview of corneal biomechanics, which is completely ignored by these systems. So this was an important paper that gave us a lot of insight about the biomechanical impact of refractive surgery on the cornea. And there were three important messages in this paper. One, that the biomechanical effects not only depend on the surgical factors, but more equally importantly, on the patient's own viscoelastic properties. Two, that it is not just the number of pulses, but the location of these pulses that matter. And three, that the ablative efficiency of the pulses themselves may be different. Even with an aspheric ablation profile, they could be different from periphery to center. So we now know that to understand the comprehensive risk, structural risk that a cornea is being subjected to, we need to integrate the three-dimensional patient-specific corneal geometry, which is what the tomography offers, with a spatial biomechanical profile, which the present-day devices do not give us, and integrate that with the case-specific surgical factors to give us a structural risk that this cornea is being subjected to. And working towards this, it was William Dubs and his colleagues who used a finite element modeling system, a computational system, to simulate different types of refractive surgeries. And they found that the maximum principal strain, which is the maximum tensile deformation that a cornea undergoes at any particular point in response to a load, and they chose the anterior stromal bed. Why the anterior stromal bed? Because that is the critical layer that resists any creep that happens after an ablative procedure. They found this to be the most predictive of a structural vulnerability of the cornea. But that, as you might realize, was done in a virtual domain. For that to translate into a clinical application is going to require a completely different software programming and the ability to map the biomechanics in a spatial distribution, which we have not yet arrived at yet. Coming to the clinical features, most patients present with the classical symptoms of a loss of quality and quantity of vision. And it is the tomography that clenches the salient tomographic characteristics, which include an inferior steepening, a thinning of the cornea, and a posterior elevation. Although there are no strict, criteria to define what you would call a post-refractive ectasia, most papers would follow the triad of features that have been described by Randleman, which include an inferior topographic steepening of more than 5 diopters, a loss of more than 2 lines of vision, and a change of manifest refraction of more than 2 diopters. But as you can see from this, by the time it reaches this stage, it is fairly advanced already. So the key is to try and detect early stages of post-refractive ectasia, because that gives you the best chance of an improvement. And in trying to do this, this was a study done in our center, where we looked at the different characteristics, the tomographic characteristics of post-LASIK ectasia. And we found that if you look at the location of the steepest point, now it's usually in the center in a normal eye. Following a myopic ablation, it moves to the paracentrally. When you start to see that it is beginning to come closer back to the center, or if you find that the point of highest posterior elevation is again beginning to approach the center, or you find an increase in the vertical coma or an increase in the negative spherical aberration, a change in the asphericity of the cornea from prolate to oblate when after a myopic ablation, and then becoming prolate again. These are early changes that would allow you to pick up a post-LASIK ectasia at an early stage. It's important to differentiate this from a decentered ablation. There's one of each in this map, and from the topography, you cannot say which is which. And making the difference is important, not just because the treatments are different, but they could actually backfire if the diagnosis was different. For instance, if it was a post-LASIK ectasia, you might want to do a cross-linking. But then if it is a decentered ablation, you would be entrenching that asymmetry into a stiffer cornea, making it more difficult to treat. And likewise, a laser treatment on an eye that you thought was a decentered ablation might actually worsen the ectasia. So this is where, again, looking into the details of a tomography help. If you look at the area of flattening, and you see that this area of thinning corresponds to that area of flattening, and there is no significant posterior or anterior elevation, this is likely to be a decentered ablation. On the other hand, if you find that the area of thinning straddles the area both of the flat and the steeper zones, as you see in this relative pachymetry map, and is associated with an increase in the posterior elevation, this is likely to be a post-LASIK ectasia. It's also important to differentiate a post-LASIK ectasia from a pseudokeratoconus that follows a hyperopic ablation. And here again, with a post-hyperopic ablation, you would find a pericentral thinning. Working towards finding an index, because the BAD-D and the CBI, TBI are no longer valid after a refractive surgery. This was a large multicentric study of which our center was part of this study, where a regression analysis was done, and 6 of the parameters from the corpus were used to create the CBI LBC, and this becomes easy to immediately click and find out the existence of post-LASIK ectasia, and this was found to have a very high sensitivity and specificity. There have been many studies trying to differentiate the biomechanical impact of different refractive surgeries. And although we know that SMILE is possibly more protective, it does not prevent a post-LASIK ectasia. This is the last slide, if you will permit me. The challenges in management of ectasia are twofold. One is to establish stability, which is done by cross-linking, and the correction of the astigmatism, the irregular astigmatism, which could take several ways of doing. But this spherical contact lens has been a complete game changer, and I think Vasha is going to be dealing with this, and she's an expert at that. So just to conclude, the treatment would, of course, depend on the stage and whether it is progressive or not. If it is not progressive, there is no definite indication for a cross-linking. I have seen patients who have stabilized even without it if they have stopped rubbing their eyes, or if they have passed their pregnancy, or their hormonal changes have ceased to exert an impact. So thank you very much, and I'm sorry for having overstepped my time by a few minutes.